Hello, good afternoon, distinguished panelists, participants, colleagues, and friends. On behalf of Next Year Health Practice, I welcome you to this vital webinar titled From Innovation to Inclusion, Scaling Primary Healthcare for Vulnerable Nigerians. This webinar brings together experts, policymakers, practitioners, partners dedicated to strengthening our primary healthcare system in Nigeria. Today's webinar aims to share ideas, explore practical solutions, and discuss how we can ensure innovative approaches to reach the unreachable, particularly Nigerians who are vulnerable. Achieving universal health coverage in Nigeria requires practical, scalable models to deliver quality primary health care to underserved populations, particularly rural and peri-urban dwellers. With persistent infrastructure gaps, workforce shortages, and weak service delivery, especially in northern Nigeria, the urgency for resilient, community-driven, and technology-enabled health system has never been greater. So across Nigeria, various innovative approaches are emerging that combine mobile technology, community engagement, and preventive care, maternal and child health services, and sustainable financing to bring healthcare closer to the people. Now, these approaches demonstrate that it is possible to strengthen primary health care while empowering communities and training local health workers and deploying digital tools to reach even the most remotest of areas. As such models offer valuable lessons for our policymakers, healthcare professionals, and investors interested in equitable and sustainable solutions. They show what it means to place innovation, inclusion, and resilience at the heart of our healthcare system. This edition of next year's Universal Health Coverage Dialogue Series brings together great panelists, which you will get to hear or know about them in due course. My name is JemChang Fabong. I'm the Next Year Health Practice Lead. And of course, Next Year Capital Limited is a multi-competency advisory firm that brings African solutions to African problems. Of course, we are chiefly involved in making our planet or our continent the best place to ever live in. At Next Year Health Practice, we do healthcare financing, healthcare communication, we do policy and research, and we have a group of robust and well-trained practitioners that work day in, day out to ensure that the citizens of Nigeria and Africa are better off. We have practices all over African countries, and we are making sure that no one is left behind. The objective for us at this webinar is to unpack the core elements of innovative models that strengthen primary healthcare. I'll be hearing from people who have divulged their intelligence and their space to making sure that our people are better off. So today's panelist, first is Dr. Ifunaya Ilobube, who is the Chief Executive Officer of the EHA Clinics, I say around the world, not just in Abuja or Kano or Lagos. They are found everywhere in the world. And of course, Professor Bala Muhammad Audu, who is the President of the Nigerian Medical Association and the Vice Chancellor of Federal University of Health Sciences, Azare, will join us in a short while. So Dr. Ifunaya Ilobube is an experienced physician leader with over 18 years of practice in clinical practice or healthcare operations and the likes. And of course, she has been involved in some robust quality management. She's the Chief Executive Officer of the EHA Clinics. In this position, she offers strategic and operational leadership with a strong emphasis on people-centered care, strengthening health systems, and fostering sustainable innovations. Worthy of note is that Dr. Ifunaya rose through the ranks of some great opportunities and positions in the healthcare to the echelon, which is the highest position that she currently sits as Chief Executive Officer of the EHA Clinics. Dr. Ilobube earned dual bachelor's degree in medical sciences and medicine and surgery from the University of Ghana Medical School. She returned to Nigeria and gained extensive clinical experience before transitioning into healthcare administration at Bridge Clinic, Facility Clinic Center, where she served as clinic administrator for 5.5 years. Dr. Ilobube holds a master's in international health management and leadership from the University of Sheffield in the UK. She's a certified professional in healthcare quality from the National Association of Healthcare Quality, the United States of America. And additionally, she is a certified lead auditor and a certified crucial conversation trainer. As Chief Executive Officer of the EHA Clinics, with a vision anchored in the organization's true north of zero harm, zero weight, and zero waste, focusing on expanding access, driving high-quality primary care, and delivering patient-centered innovation across Nigeria. You're welcome to this series, Dr. Ilobube.
Thank you so much for having me, and I hope everyone can hear me very well.
Yeah, so while I was introducing you, Professor Bala Audu called, and I think probably he's trying to let me know that he will be running late. But I'll also give a brief on Professor Bala Audu before he joins us. Professor Bala Audu is President, Nigerian Medical Association and Vice Chancellor of the Federal University of Health Sciences, Azare in Bauchi State. Professor Bala Audu, as a distinguished obstetrician and gynecologist, with a notable career in clinical practice, academia, and the leadership. He has served as consultant obstetrician and gynecologist at the University of Maiduguri Teaching Hospital since 1998 and headed the department at the Federal Teaching Hospital, Gombe, between 1998 and 2003, and led the department again at the UMTH between 2004 and 2007. He was chairman of the Medical Advisory Committee clinicals at University of Maiduguri Teaching Hospital and became a professor of obstetrics and gynecology at the same institution. Between 2017 and 2022, he served as professor and provost of the College of Medical Sciences, Abubakar Tafawa Balewa University, Bauchi. He has held key leadership roles in the Nigerian Medical Association, Society of Obstetrics and Gynecology, that's SOGON. And of course, he's a Chevening scholar who received the Bill and Melinda Gates Foundation Research Grant. His scholarly work in gynecology, oncology, infertility and maternity, maternal mortality has increased to the body of knowledge. He is currently the Vice Chancellor of the Federal University of Health Sciences, Azare, and at the same time doubles as the President of the Nigerian Medical Association. So I'm sure Professor Bala Audu will join us in due course. Dr. Ifunaya, how have you been?
Been good. Abuja is a little cold today, but very good.
Oh, so it's great to have you join us on this platform. Amazing job you are doing at the EHA clinics. I've been to the one on the airport road, and then I've been to the one at Life Camp here in the city center. And I must confess that it's a great innovation you have done in that regard.
Thank you. That's so kind of you to say.
Yeah. So just like I said, this discussion, it's a practical approach to driving solutions to the myriads of problems in the African setting, particularly in Nigeria. We do not believe in the usual sitting around to be talking and then running around that vicious cycle where there is no impact. We've seen impact in what you're doing. And I'll just ask you as we kick off these discussions that what are the most significant logistic and systemic obstacles your clinic had faced in reaching the poorest in most remote communities, and how have you overcome them? Because healthcare, if you take out the private sector in healthcare, I do not know where we would be. So would you just educate us on the most significant logistic and systemic obstacles your clinic have faced in this regard?
I mean, logistics is easy to understand. I think the logistics issues are not peculiar to healthcare, right?
Yeah.
The fact that there's poor power, poor road infrastructure, unsafe road travel, when we talk about power, transporting things like vaccines and making sure that the cold chain is maintained. Those are the typical logistical issues that affect every business in Nigeria. But one of the most interesting systemic issues is something that is very peculiar to healthcare. Healthcare is a trust business, which means that even if you find your way to those communities, if they don't trust you, they will not come. And because of that, even if you build a fantastic healthcare center in those communities and they don't trust the doctors or trust the nurses, when it comes times to delivery, they will still go and deliver at those traditional birth attendants who are in the communities because it's a trust business. So very early on, we understood that being able to deliver care in those underserved communities meant that we needed to partner with the people providing some level of care within the communities who the community trusted in order for us to be able to make even any significant headway. Another systemic issue, and this is not just for underserved communities, is the healthcare regulatory system in Nigeria is very fragmented. Every state has its own requirements. Every local government has its own requirements. So just because I have successfully set up a clinic in Lagos, Kano State doesn't care what I'm saying. They have their own regulatory requirements, some similar, some completely out of left field. So it almost seems like for every clinic we start, we are learning new lessons about how to set up in that particular state. So it makes scaling very complicated because it's not just plug and play. There are requirements that are sometimes just niche for that particular environment. And those are some of the interesting things we've learned so far.
I love the way you took the discussion to not just a question of having systemic and of course challenges in the rural areas or in the urban center. It's good to navigate deep into the fragmented systems that we have in place. And of course, the fragmented system in place has not helped healthcare delivery in Nigeria by any means because of we operate a federating system, but of course every state has some laws that governs activities of healthcare delivery um, in their states, and that makes it a little bit Herculean for us. So part of what we had dealt with is the question of trust. We've always said that is the single most important currency with healthcare delivery. And if you know, across Nigeria, we have different cultures and different traditions, and sometimes it's a bit sensitive to begin to navigate those turbulent waters. But of course, we also have a challenge with affordability and sustainability in service delivery, especially in areas where households live below the poverty line. But I and the founding partner of Next Year, Patrick Okibo III, had always said that Nigerians will always pay for healthcare services wherever they are, so long as they are sure that they will get those services. So the next question to you is, how do you balance this question of affordability with sustainability in your service delivery, owing to the fact that most of these people in these rural and peri-urban areas do not have any form of health insurance cover?
That's a loaded question. And you brought up something very important. People will pay for healthcare, but sometimes the people they pay are not who you expect them to pay. And like I said, one of the most interesting things we found was healthcare is going on. It may not be happening traditionally at the PHCs that are provided, but every day somebody is going to PPMVs to pay for injection EMA because they think they have malaria. So which means that people are paying something, right? And it's trying to work within the scope of what people understand. You know, sometimes for a lot of us who come from, I guess we can call it privileged background. We're coming from teaching hospitals, we've learned medicine, we think this is how healthcare can be delivered. You know, it's the same way when we're building digital products, we build it with assumptions that this is what people need. One of the most humbling things is finding out what people will want to pay for and how people will want their healthcare delivered. So we'll talk about insurance as a separate thing, but one of the things that we looked at was how to make healthcare affordable. What really are the health systems issues that drive, you know, first of all, patient outcomes and affordability? Let's look at availability of essential medicines, right? There are medicines in these communities. Are they good quality? And is it possible to get quality medications with, you know, reduced markups that patients are able to afford? So they are going to these PPMVs, but making sure that these people are able to, they're able to get, you know, medications they can afford. The other thing is, no country has enough healthcare workers. Nigeria has, in some states, severe deficits of like one doctor to 5,000 patients. So how do we find ways for people to get some level of care without putting a doctor there? And that is where the conversation around using digital tools and using technology to bridge the gap. And this is not necessarily just telemedicine, right? Because sometimes when you talk about bridging the gap of access, we'll say telemedicine, let them talk to a doctor here. But they are presenting to a PPMV. Can we put tools in the hands of these PPMVs that help them using clinical decision support and some artificial intelligence with some guided workflows, at least be able to triage patients appropriately and treat simple things and refer things that are more complex. Those are some of the things we think about when we think about making things more affordable, because if I put a doctor there, the cost of that service already goes higher. I think the last thing in terms of affordability is, I mean, right now everybody's going through the funding dearth, right, in the nonprofit space. But even when we had funding and there are a lot of nonprofits in the country, a lot of the programs are really fragmented. So somebody is running an HIV program in the hinterlands in one state, somebody else is running a nutrition program. So these programs are going on, but there's no weighted impact because it is fragmented. What some of the things that we've also tried to do with some of our community programs is using our community clinics as anchors for some of these public health programs. So somebody is running a public health program on antenatal, come and run it through our clinic. So it means that at least ANC care will be free. In the same way, somebody is running free vaccination program, running through our clinic. So at least vaccination care is free. Somebody is running a malaria testing program, running through our clinic. We remove the cost of malaria. Somebody's running an HIV intervention, we run it through our clinic. So by aggregating those services, we're able to bring down the cost of care significantly. I think those are some of the things we've done. But that being said, as a country, we need to figure out health insurance, how to aggregate the uninsured, how to use PHCs and in the community to serve as sources, a place where people can actually be registered under the insurance, because what makes insurance work is the critical mass. Even if everybody in Nigeria, and this is a random number, we're able to generate 100 naira, you know, from everybody who registers, it's a mass that we can use to pay for healthcare. But right now, today, we are struggling with under 10% of people with insurance. And it's something that we need to figure out in order to keep our healthcare sustainable?
Thank you. You mentioned something that is striking in this discussion. You said beyond the fact that Nigerians are able to pay for healthcare services, to pay to people they trust, which is why a babalao by the side or a prayer house by the side, people will take chunk of resources, there are a lot of money, some of them have sold their lands, sources of livelihood, to visit one spiritual center where they are told what they want to hear. So that also centers on the ethics in healthcare practice here in Nigeria. And so it's good that to note that beyond what the government is providing, we too as healthcare providers will need to up our game and then create that confidence in the system so people can see us. With great insight there concerning how we manage expectations with affordability. And of course, this underscore why the Nigerian Health Sector Renewal Investment Initiative, the sector-wide approach has been brought on board. Of course, because most of the programs that we had in the day we had funding from international organizations were vertical programs, and everyone operated in silos. But the coordinating Ministry of Health is saying, why can't we have just one program, one plan, one budget, one M&E, and then we can have possibly one outcome? And I'm sure that's what the model that you have brought in the EHA clinics that the federal government is attempting to implement in Nigeria. So I visited your clinic and the live camp, and I saw an amazing telemedicine setup that is adequately equipped, like one of those centers I visited, like the King's College Hospital in London. So this question is, what insight can you share on using mobile technology and telemedicine to deliver care and build trust amongst rural populations who are skeptics of modern healthcare systems? I know you've you've encountered some of those skeptics. You know, I share something with you before you give me this response. While training as a houseman in 2005, a certain Fulani man was referred from Adamawa to the Jos University Teaching Hospital. And prior to arrival, they told him that what will make his child get better is if they put the child in a computer. So the man came, and every clinical findings was towards rheumatic heart disease. But I looked at the man's countenance. For whatever we said he should provide in the 3 days he was in the hospital, he was very hesitant, because someone had told him that the child's problem was to be put in that computer. And of course, the third day, I now suggested to Professor Bode Thomas that shouldn't we do an echo? And Professor Bode Thomas said, okay, can I explain to him? I told him we have a probe somewhere, we'll lay the child down and then try to put the probe on his chest and it'll show us images on the computer. He said, yes. He said, that's exactly why he's in Jos. And from that going forward, we had his cooperation, and the child didn't stay beyond a month in the clinic. So of course we have skeptics. And so what insight can you share on using mobile technology and telemedicine to deliver care and to build trust?
I mean, and this is technology in general, with regards to technology in healthcare. It's not a nice to have anymore, because it's not something. In order for us to bridge the significant healthcare gaps we have, technology is the answer. It's not, we don't have enough doctors, we don't have enough nurses. So in order for us to be able to serve as many people and create as much impact and get as much data that we need to improve patient outcomes, technology is the next bastion of healthcare. So I wanted to start with that. But that being said, implementing digital health programs and digital health products have, over the past 6 years as EHA Clinics has been really interesting. EHA Clinics started, especially in Abuja, at around end of 2019. And then in 2020, in March, we went into COVID. So, there was widespread panic. And it's created a lot of mass adoption of digital health products and telemedicine because we were locked down and we have to find, innovative ways to deliver healthcare delivery. I wish I could honestly tell you that a lot of the learnings we took remained, because I always laugh about telemedicine that even when it is free, I can't even give it away for free because what patients thought were comfortable doing with telemedicine during COVID, it's very hard to get them to do it now because people still feel like they will feel better if they are talking to somebody and the person can see their face and touch them.
Sure.
And that is where trust comes in because they've gotten used to a model of care.
Yeah.
Change, as constant as change is the hardest thing for us to do as humans. So COVID forced the change, but the change could not be sustained because it was a change that came out of duress. So it's hard to sustain. So even till date, we've had to find different models for telemedicine. And telemedicine, a lot of people think it's just what we're doing right now, video conferencing. Telemedicine is AI bot chats, right, with patients. Telemedicine is talking to and I'm sure as a doctor you get that your mother will give your number to everybody and people will be sending you messages on WhatsApp. That's telemedicine. Telemedicine is consultations over the phone. So people are more accepting of phone calls because phones and GSMs and have been around for a long time. They are more accepting of WhatsApp because everybody's church group has WhatsApp messages. So everybody's on WhatsApp. But the video conferencing is still something that people are getting used to, right? With any kind of implementation of technology, it's always important that when you look at it, I don't want to use the word pilot, but it's pilot. When you implement, you look at adoption and look at what the barriers are to adoption and try to adjust. So when we've implemented telemedicine and we could see that nobody wanted to sit in front of us, we said, what would you prefer? A call, a WhatsApp? And we pivoted, right? So
Right.
I think that is the most important part. Know your audience, listen to your customer, and be able to pivot appropriately to deliver the care that they will be able to trust. When it comes to the adoption of mobile technology, for us, it was a no-brainer because how do I improve what I cannot measure? And how do I measure when everything is on paper? So I have being able to have electronic medical record systems, enterprise resource products that help us to kind of aggregate the kinds of patients we're seeing, the disease processes, so we can predict what is going to happen next season. I mean, it's raining now. From our predictive models, we know that our hospital admissions will peak in the rainy seasons because of malaria, and we plan appropriately for it. We also see, okay, all of a sudden, our typhoid positivity rate is high. What is happening? Do we want to start pushing vaccination for our patients? So I think when it comes to adoption, people need to see how things will benefit the provider and being able to provide better care, more efficient care, and benefit the patients in being able to provide a higher quality of care.
All right, thank you so much. Before I also ask a question that is related to this, we want to thank our participants for participating. We have the question and answer box as we engage Dr. Ilobube Funaya. Please, if you have any questions, kindly drop them in the Q&A session. Dr. Ifunaya agreed that telemedicine has helped a lot, and of course, it has reduced access barriers. But of course, how have you coped with the cost of service delivery when you are using that means to deliver healthcare to people?
Healthcare will always come at a cost, right? For us, because we already have integrated electronic medical records, it means that data is something that we have to have, right? So it's being able to work out the cost of that data not just for ourselves, but also for the patients, right? A lot of the times, yes, there's a big startup cost. And, you know, in terms of what we have invested in to get started with telemedicine, that is because we had that cash, right? No, today, nobody needs to invest that much to start telemedicine. With a mobile phone, empowered with a camera, you can do telemedicine. So it's nice to have the big card, but that should not be the barrier to any doctor or any provider being able to provide that care. We look at costs as maybe a little differently. As much as it's important for us to be sustainable, it's important that patients are able to access our care. So we know that healthcare within Africa, or generally, healthcare is a long game. Anybody who is planning to invest in healthcare and get their money back in 5 years will not get it. They'll be frustrated. So we're playing the long game. We understand that it's a long game, it's a trust game, and we don't have to kill the patients with cost to get there. It does take time. The results will come eventually.
Well, so thank you for allaying the anxieties that many Nigerians have with access to healthcare through telemedicine. Mentioned that I've been to your clinics at the airport road, been to your office here at Life Camp, and you have one in Kano and one in Lagos, or probably. So as you expand geographically, what are the key lessons that you have learned in maintaining quality and continuity of care, particularly the conflict-prone or culturally conservative areas that you intend to navigate?
Key lessons. So yes, funny, ironic, in Abuja, we actually have 3 clinics. So we have a clinic in the community in Kuje. And I think some of the key lessons we have learned. So at EHA Clinics, we look at everything through the lens of what you've mentioned, which is our true north. Our true north helps us decide what is important and what we can shelve that is not in the interest of our true north. And one of our true north is quality and patient safety, which means that when we think of scale, if the scaling is going to water down the service we are going to provide, we won't do that. We don't want to be too big that we are not able to monitor the quality of service delivery we are doing. As I sit here, because of the electronic medical record system we have, I have a dashboard that shows me what every clinic is doing at every time, the patients they are seeing. I can see all of that. So when we are thinking of quality, when we are thinking of a clinic, we think of 3 main things. Where we are going, how is this going to improve the quality of care?
Yeah.
How is this place, what is this going to add any value, right? And is this in the interest of impact and health equity? So those are the kind of mindsets we kind of have when we are going into scaling. So as much as we think of scale, of course, for primary care, the more locations we have, the better it is because it means more people have access. But we don't want to grow to the point that it becomes manageable. So as we grow, we ensure that we are building structures, building systems, employing people, creating data systems that help us aggregate and measure the outcomes and the impact of what we're providing and ensure that we are sticking to our true north. The other thing we do is listen to our customers. We have a very robust customer service feedback form. We always make sure that if a patient leaves a negative feedback, we get back to you within 24 hours. What that means is that we are always listening to what our customers think is good and we're improving. Because like I said, you create a product and you think, oh, fantastic, but your customer is telling you no. And you have to have the humility to say, okay, this was an assumption. The assumption isn't working. And how can we pivot? to ensure that our clients are satisfied. And we always think through the lens of impact. This service that we're delivering, this clinic, how are we going to be able to impact the community that we are operating in? What does it look like? Are we planning to do outreaches to ensure that the community, has access to health education, has access to things like birth control services, vaccination plans? What are we planning for the community? And very importantly, we think about how are we going to be able to impact, how are we going to be able to hire the right people, right? I was just talking to you before everybody joined. That's one of the when I used to employ directly and I see a doctor's CV from University of Jos, I used to be very excited because you produce fantastic doctors. But in every city, I need to be able to replicate the standard of care. So being able to find appropriate manpower, engaged manpower who is able to have the same quality ethos is important. And of course, we think about financial sustainability. I want a situation where you come 10 years later and there's still an EHA clinic standing. So that is how we think of it. So not to overextend ourselves so that it's not sustainable.
Hi, Funaya. You could see me just smiling. I'm so happy that you mentioned the prestigious University of Jos, Nigeria. That's my school. So I love it. So now back to the question of interdisciplinary collaboration, because primary care itself is frontline care, and of course where we see patients strictly in their undifferentiated forms, and I'm sure that's your experience with the EHA clinics. So how have you been able to create the balance so a patient does not walk in and then something is lacking, or he goes back to say, this clinic does not have all we need?
So, which is such an interesting thing because this conversation is driving why a lot of patients that should be in primary care go to secondary care, because what is all you need? The truth is 85% and sometimes even 90% of what patients will need can happen in primary care. If you have general practice doctors, family physicians that are able to deliver preventative care, things like annual health check, vaccines, as well as acute care management, appropriate diagnosis, and referral, a lot of that can happen in primary care. I think what this mindset, because till to date, we still get patients who come in and say, I need to see a gynecologist. And you ask, what is the problem? And then the patient says, my periods are irregular. My periods are irregular can mean the patient has polycystic ovarian syndrome. A well-trained family physician, a well-trained, general practitioner can actually make that diagnosis and then refer to a gynecologist. Patients will walk in and tell me things like, I need a pediatrician. What is the problem? The child has cough and catarrh, right? So it's this mindset that only specialists can see certain cases, when nowhere around the world is that true. In the UK system, in the NHS, you will struggle before they refer you because 90% of what you will need will happen at your general practice doctor. We need to look at our primary care system again, because if all our patients end up in secondary care facilities, first of all, they'll be overburdened. And second of all, we cannot afford it. So we need to find a way to strengthen the primary healthcare system so that they can handle that foundational level of care, those health interventions, those preventative, because when I say prevention is better than cure, it is cheaper to prevent than to cure. Let me use an example. What's the cost of a typhoid vaccine? If you do a multi-dose vaccine, 5,000 naira. What is the cost of treatment for typhoid? The consultation it's going to take, the tests, the IV fluids, especially when the person has a severe case, versus a 5,000 naira consultation.
And of course, and that's just the direct cost, right?
Exactly.
So you begin to talk about intangible cost like loss of man hours, cost of travels, and the likes. Yeah, go ahead.
Yeah, so exactly what I mean. So a lot of the times we think about, and it's also the way even insurance is designed. Insurance in Nigeria is designed in such a way that it's acute focused. So feel like you have a fever, you go and get tested. They say you have typhoid, you treat. But if I go to say insurance company and say pay for typhoid vaccination, they won't. But meanwhile, this will prevent you future cost of paying for a typhoid treatment, right? So it's very interesting, and we need to find a way to reposition primary care as what it truly is, which is the bedrock of healthcare provision.
Thank you for this amazing insight. It's just super discussing with you. I'm sure, yeah, the model that you operate is not just a standalone. There's some form of partnership. So, what specific types of partnership? Do you have the public sector partnership or philanthropic or community based, or what are specific types of partnership have been the most critical to scaling up the EHA model, and how can that be deepened or be replicated?
You know how they say AI is the new buzzword. I think partnerships should be the new buzzword in the sense that you know that African adage, it says if you want to go fast, alone, but if you want to go far, go together. It's nothing is more true of, no statement is truer than that in healthcare. You can't do everything by yourself. You
Yeah.
just can't. Um, as great as my lab is, in order for me to be able to provide the full range of laboratory services, I would have to invest very significantly, right, in equipment. So instead of doing that, why don't I find a partner that is like-minded, who's able to, has the same quality ethos, and we combine efforts together to be able to provide the care of patients. We need to move away from that traditional mindset of everything must be only us. The pharmacy must belong to us. Everything must be us. If there are people within your sphere that do things better than you, why not work with them, right? That being said, it's a mixture of partnerships. Of course, private partnerships is in some of our service provision lines. But one of the things that we are doing right now is moving into public partnerships with state governments, because we also understand that true health equity is not going to be won in Abuja. We need to be able to go to Katsina State and replicate what we're doing here, because the people of Katsina State do that. So we're looking into that. And like I said, philanthropic is, we work with a lot of nonprofits, and with our community clinics is running those programs through our community clinics so that we are able to, reduce this fragmentation of care, reduce the cost of the care, and provide better value for the patients. So we are building what we're building with so many different partners, because we believe that the whole is always better than the sum of its parts.
Yeah, so Ifunaya, would you want to touch a little on the funding?
Funding for which one?
Yeah, for your model. Yeah. Yeah.
So, I mean, we are privately funded, but a lot of our community health work is funded through different partners, different nonprofits, through research grants, through different programs. We also work extensively to partner with even faith-based and nonprofits, organizations who want to run clinics and may not even have the know-how. So yes, we are privately funded for the most part, but also look at different avenues to pool funds so that we can make the service more affordable for clients.
Fantastic. It's been our greatest pleasure having you on this webinar series. We have a couple of questions that have been asked by our participants who have been patient listening, and gaining from your wealth of experience as you executed and continue to execute the EHA models. So I'll look at some of these questions, one of which is from Elvis Igbenovia. He said, if telemedicine is delivered by any mobile app, how do you do so without compromising patients' privacy, fragmenting care, and ensuring continuity of care?
So I think maybe not to be misquoted, not by any patient app, any patient mobile app. And I think, the issue of data privacy and a lot of the conversations around patient information is important. It's important that in those patient interactions, in any patient interaction, there is some consent taken. And that's a step sometimes we miss in Nigeria. You just start having a conversation with a patient and not taking consent. Consent because you will need data from that patient, either to store it or, in order or to share it. So first of all, how are you taking consent in having that conversation? Where are you documenting that interaction? Is that interaction through an encrypted, encrypted application like WhatsApp, right? Because one of the good things about WhatsApp is that it's encrypted, end-to-end encryption. Are you recording? And have you taken permission from the patient to record? I mean, even when we started this, we had recording in progress because patients need to know that they're being recorded, right? And now that you have the data, what are you doing with it after? That's why patient consent is important. That is why whoever is doing telemedicine has to be licensed to do it, has to be a licensed provider who's allowed to have that information, right? And also, it's also how we give patients access to the information we've collected from them. I always say that patients' data is theirs. So they always tease me in the office. I don't understand why people should pay for medical reports, because in my mind, a patient's information is theirs. You should give them back their information. So definitely consent is key. Number two, ensure that the app has encryption. If conversations need to be recorded, the patient is consenting to that, and that whatever place that you are gathering the information is private. So putting patient information in a notebook that you are now going to leave in the consulting room, leave in your office and go away, not in the interest of patient confidentiality.
Yeah, and I also know reliably that most of our clinics, if not all, work in tandem with the National Data Protection Agency, because data and safety and privacy is a very sensitive aspect of medical practice, which we do not take lightly. And of course, the MDCN will not just offer you licensing or the geographical area where you practice. The governing body there does not just give you licenses if they are not sure that you have what it takes to prevent loss of data for patients. Because Elvis Igbenovia is still asking, they say, how do you get affordable care to underserved remote areas without deploying technology? He said, really, I'm not too sure if that was said, because all will have some form of technology deployed. I understand, of course, telemedicine has different platforms. You could even use phone consultations without just videos, and telemedicine could simply mean to even make calls on the phone to get to standard. Now, so Anthony Ayeke said this is an interesting discussion. Thank you. As a development partner, we are looking to catalyze more value-based investments in the health sector, including on digital health solutions. So what advice do you have, especially from a preventive healthcare perspective?
Interesting. First of all, whenever people tell me about deploying healthcare solutions, I always tell people, don't get bogged down trying to solve one niche problem. Think about the patient interaction as a journey. And whatever digital health solution you are deploying has to be able to contribute value in that journey. So let me use telemedicine as one of those things. So a lot of conversations about telemedicine. Now, one of the drawbacks to telemedicine is the fact that, number one, you can't do testing. Number two, you have to think about medication, how medication getting to patients and things like that. And even with the deployment of telemedicine within our clinics, we had to think about that. If I'm doing telemedicine for a patient in Port Harcourt, I don't have a clinic, but I have a partner in Port Harcourt I can send for that patient to do labs and I'll get the results. I don't have a pharmacy, but I have a partner that the patient can go and pick up those medications. So when you're coming up with digital health solutions, you need to think about the journey, the diagnostic process. I think when it comes to preventative care and the deployment of healthcare solutions, I think keep it simple, right? One of the simplest, most overlooked areas in the deployment is vaccinations and how to track vaccinations and how to ensure that safe vaccines are reaching people. Vaccination has reduced worldwide mortality across worldwide for many years, but it's one of the areas that till today we still have a lot of hesitancy, right? Barriers to access, things like that. How can we deploy digital health solutions to think about that? The other thing is thinking about, and this is coming from preventative care, but a little differently. When we think about healthcare financing, especially for things like insurance, like I mentioned, we are very active. Can we develop digital healthcare products and insurance products that promote preventative care? For example, in a lot of HMOs in the US, if you get your flu shot, if you get your annual health check, there are points that accrue to you that can reduce the cost of your premiums the next year. Have we thought about how we can use digital health to track people being able to do that and actually reduce the cost of their premiums by proactively taking care of their health, which at the end of the day will reduce the cost of care to the HMOs? So I think those are the things I think about. Those are things that keep me up at night.
Thank you so much for that amazing response. Last week, I gathered reliably that Zach Health in the UK has entered into a partnership with Impact International in Nigeria here. And of course, they are working with Peramari HMO to deploy the AI facial biomarker scanning that could dictate things as mental risk score and could as well help with the wellness campaigns and also with stratification and risk equalization with the pool and stuff. And I said, that's an amazing idea. I'm pretty sure it forms part of both preventive health and promotional health as a component of attaining universal health coverage in Nigeria. So John Issa asked a very interesting question here. He said, how can we close the gap in emergency healthcare delivery? Use of ambulances, rapid response services, etc., with the model that we are discussing. Very interesting question.
I always say that the person who can solve this problem will probably rule the world. So I think if we look at it from a costs standpoint, we're underinvesting in healthcare. Underinvesting meaning that we're not training enough healthcare professionals. We are not except for maybe like University of Benin, how many other universities train people like paramedics, right? So even the healthcare workforce to be in these ambulances are not there. So let's even start from that part. We don't have enough healthcare workers. We're investing in healthcare, in the education of healthcare workers to even train these ambulances. Even if the government was to put 10,000 ambulances on the road, who is going to be inside? Right? So there's that problem. Now there's now the investment in the hardware, buying the ambulances, running these ambulances, maintaining the ambulances, which is one of not our superpower in Nigeria. But how can we right now, with what we have on ground, improve our emergency medical system in Nigeria? Start with what you have. There's this really partner we work with, Emergency Response Africa, and they were doing this partnership in Edo State, where they were creating these keke ambulances, right, to help transport people, with community healthcare extension workers who were trained in basic first aid and CPR in being able to transport these patients. But if the majority of ambulances in this country are privately owned, the question is, how can we consolidate all these privately owned ambulances into an emergency management system that works? I spoke to an interesting team at the Africa Digital Health Summit, and they're trying to create something interesting like an Uber for ambulances. Yeah. Right? Where basically the ambulance, somebody would make a request and the ambulance would, the closest ambulance that picks it up will be able to respond. And it's such an interesting idea, but the problem is who is going to pay for the ambulance, right? So somebody makes a request, who is the payer? Is the government like what they do in the US, which is if you go to the ER, it's free. Is there going to be provision that as long as you respond to an emergency, you're going to get paid? Because that's one of the restrictions. You respond to an emergency, you tell them this is the price, everybody's like, but this one. But if we create this Uber, are patients able to put their card on so that we know that this person is going to get paid? Are all the ambulance services going to agree to charge the same thing, right? How are you going to make sure that there's quality control on the ambulance? It happens with Bolt. Bolt is supposed to have AC, but you enter in some places and they will not put AC. Well, some ambulances forget to come with oxygen. So it's complicated, but there are possibilities. And it's interesting in Africa, right? Because we have so many models around the world that we can copy. Sometimes we don't do that.
Yeah, and I think part of the solution was at the deep dive that we did while I served as Director of Health Financing for the USAID IHP project in Nigeria. And we discovered that the number of women who attend an antenatal clinic outweighs the number of women who eventually return to the primary healthcare centers to deliver. And part of the challenges is transportation, some of them are emergencies and the likes. So part of the solution we had was to incorporate some form of transportation into the premiums that we pay for the basic healthcare provision form 2.0 that is coming. Dr. Ifunaya Ilobube, it has been the most amazing opportunity having you on the next year UHC webinar series. Your insight has been very, very amazing. You spoke from the practical aspect of implementing primary healthcare solutions to the myriads of challenges that we have. What last word do you have for us? Because what actually you are doing is part of what the key project for the next year health practice, which is the Frontier Clinics, is about to take off with a pilot in Plateau State particularly. And of course, we are trying to replicate a model like yours, but ours is more in the rural areas, and we've been doing some incredible work in that regard. So what last word do you have for us today on this webinar before we close? Oops,
I think,
another question just popped. And
wow.
well, okay, it's Elvis that came. It's a great conversation. Be a forum for aggregating the ideas being mulled here. Thank you for making this happen, and appreciation to our very insightful panelists. So Ifunaya, it's not just me that have experienced the greatness in you. Even Elvis, who asked question, have come to that place of understanding that you have great insight into. And of course, Elvis, we are not just about the webinar. We have aggregated information and have shared with people at the topmost echelon where decisions is being made concerning healthcare delivery in Nigeria. So over to you, Ifunaya.
I think the easiest way to say this is in the words of Nike, just do it. In the sense that I know that the temptation is when you look at the financials, you want to go secondary care, you want to go tertiary care, and that's great. But if we look at what is sustainable, what our people can afford, and what is going to serve the greatest portion of our community, and the only path to health equity, I think primary care is the way to go. And those would be my last words.
Thank you so much. Before we close, Salem Maren asked, he said Nigeria invests 3 to 4% of its GDP in total on expenditure, with government expenditure accounting for less than 1% of GDP. Now, how do we improve government allocation of national budget to healthcare? Well, of course,
I was going to say this is outside my pay grade.
Just want to let him know that, of course, Nigeria is a signatory to the agreement that was done here called the Abuja Declaration, that we have said nothing less than 15% of the total budget should be allocated to healthcare. But of course, we have not seen that happen with successive governments. One of the government that tried to improve was the Goodluck Jonathan's administration, where at least we recorded up to 8% of allocation to healthcare. And of course, we saw that when the president signed the National Health Act of 2014, which birthed the Basic Healthcare Provision Fund. But of course, President Muhammadu Buhari also did something, but of course, it hasn't reached the Abuja Declaration. President Bola Ahmed Tinubu had doubled the allocation, but still it has not met the Abuja Declaration. Now, we have seen with some states, for instance, Sokoto, Bauchi, and then we have Ebonyi at some point in time had even over 20% of the allocation. But of course, it's not just having allocation. Are these allocations being released? For what purposes? We discovered that most of those releases were for capital projects, which are, what they be like. But of course, we've always said that citizens have a very important role to play in this regard, particularly budget tracking, and then demanding the government that represents them to not just allocate, but to release to healthcare. And of course, if you look at the budgetary allocation also in Nigeria, it's like putting a pyramid on its head, where 80% of the resources is allocated to tertiary centers where only 20% of people present, and then 20% of the resources is allocated to primary care where 80% of the people present. So this also gives us an opportunity to begin to ask the people that represent us what they do in that regard. So earlier mentioned, I said this webinar brings together experts, policymakers, practitioners, and partners who are dedicated to health system strengthening. Yours sincerely, Ifunaya, have availed herself, and your presence here and your commitment to promoting primary healthcare across the country, it's commendable. We thank you for the sacrifice of your time to be with us, and of course to our participants who have remained with us. We thank you once again for joining us. We look forward to engaging insightful and productive sessions in the future. Thank you so much for being part of this. We are grateful to have you.
Thank you so much. And thank you to the Next Year team for having me.